Good morning, everyone. So from today onwards, we are entering into the lower limb fractures. So in this, big class of lower limb fractures, the first topic would be fractures of the proximal femur. That's what we are going to do today. After that, I'll move on to the hip joint dislocation, and then fracture of the shaft of the femur, fracture of lower end of the femur, then fracture of tibia and fibula, and fracture of the ankle joint, okay, or near to the ankle joint. So these are the different things we are going to talk in lower limb fracture, and then we'll move on to the general orthopedics. So today, let's talk about hip fractures. Now see here, let's start with some of the very relevant anatomy. So this is the proximal part of the femur. It is a femoral head, it is femoral neck, this is greater trochanter, and here is lesser trochanter. Okay, this is called intertrochanteric line. This is always anteriorly. Intertrochanteric line is present anteriorly. Now, these are very important structures. So let us repeat again, because you have done this anatomy long time ago. So probably you have forgotten. Head of the femur, neck of the femur, greater trochanter, lesser trochanter, and intertrochanteric line. This is the shaft of the femur. Now, if we see femur from the posterior side, okay, the proximal part of the femur, then this is known as intertrochanteric crest or simply trochanteric crest. Intertrochanteric line is present anteriorly, whereas intertrochanteric crest is present posteriorly. Okay, don't forget that. So greater trochanter, lesser trochanter, this is gluteal tuberosity, and this is known as linea aspera, and this is the pectineal line. These are some other additional structures which are present on the proximal end or part of the femur. Now, this head of the femur, okay, will articulate with which structure? It articulates with which structure? Yes?
Acetabulum.
Exactly. It articulates with acetabulum of pelvis. Okay, acetabulum of pelvis, and that is called hip joint. This area, this neck of the femur, is relatively weak structure, especially in the elderly population after the menopause, in case of postmenopausal women, and in case of elderly male beyond the age of 70 to 80 years. This neck of the femur fracture is very common, but in the young adult, this fracture is not that common. It is common only when there is a very severe type of injury. Now, this topic is about the fracture of the proximal end of the femur. So let's try to know about what are those fractures. Okay, see here. Roughly, this fracture is divided into two parts: intracapsular fracture and extracapsular fracture. Now, this capsule is the capsule of hip joint. And what is capsule? What do you mean by capsule of any joint? What is that? Anybody?
Covering.
Exactly.
Covering the article.
It is a covering of the joint. Okay, this is especially made up of fibrous tissue. So this is known as fibrous capsule, and it is reinforced from most of the side by the very strong ligament. It is reinforced by the ligament, but it is mainly made up of fibrous tissue. So this is also known as fibrous capsule. Inside this fibrous capsule, there is synovial membrane. Okay, capsule is not a synovial membrane actually. Capsule is a stronger structure which gives support to the joint. In this case, we call it capsule of the hip joint. Now, if fracture occurs inside that capsule, we call this intracapsular fracture. And if it occurs outside but is still occurring in the proximal part of the femur, we call it extracapsular fracture. Very easy classification. Now, these are intracapsular, fracture site. See this line, okay, is the proximal one. This line is the distal one, proximally, that question must be coming in your mind, where is this capsule attached? So proximally, this capsule is attached, okay, on the boundary of acetabulum, on the boundaries of acetabulum, and distally it is attached right here, okay, in this line. This is known as intertrochanteric line. Very easy to remember, intertrochanteric line, exactly at this line. And posteriorly, it is attached very near to the intertrochanteric crest. Actually speaking, around 1 to 1.25 centimeter above the intertrochanteric crest. But we don't need to know in that much detail, if you simply remember anteriorly intertrochanteric line, posteriorly intertrochanteric crest, your answer would be accepted, because that is a exact area where a capsule of the hip joint is attached. So if a fracture occur inside this capsule, we call it intracapsular fracture. Now there are so many different types of intracapsular fracture. Okay, we'll talk about that extensively in today's class, but still right now you want to know about it. This is just below the head, so this is called subcapital fracture. Okay, subcapital fracture. In the middle of the neck is called transcervical fracture, right there in the middle of the neck. And this one, okay, basal neck fracture, means this is the basal part of the neck. So there are three types of intracapsular fracture. Now regarding the extracapsular, it is clearly shown there. Just pay attention. Okay, see this trochanteric fracture, also known as intertrochanteric fracture, transtrochanteric fracture, and subtrochanteric fracture. So intertrochanteric or just trochanteric, transtrochanteric, and subtrochanteric fracture. Now subtrochanteric fracture is up to 5 centimeter, okay, from this lesser trochanter area, 5 centimeter distally, and from this 5 centimeter boundary, shaft of the femur fracture will start. So this is a small, boundary you need to remember, 5 centimeter distally to the proximal end. After that, shaft of the femur starts. Okay, let's move on. Now again, okay, the same concept which we talked just now is shown in the picture. This is femoral head. Okay, this is the distal attachment of the capsule. This is a capsular attachment. So in between these two lines, we call it intracapsular fracture of the neck of the femur. Intracapsular fracture of neck of the femur. Now this is extracapsular fracture of the proximal end of the femur. It is known as intertrochanteric fracture between the two trochanter, greater and lesser. This is transtrochanteric and this is subtrochanteric up to the 5 centimeter distally. Now with this knowledge, let's talk about one other very important anatomical aspect, that is blood supply of proximal femur. Now why this point we have to know? Remember, in case of intracapsular fracture of the neck of the femur, one of the very common complications occur to the head of the femur, that is avascular necrosis of the head of the femur. So to know that important pathology, we need to know about certain anatomy, that is what is the blood supply of proximal femur, from where it comes. So let's focus here. It is coming from the different sources. Okay, look at these sources here. Inferior division of the deep branch of superior gluteal artery. Just remember superior gluteal artery as one of the source. Ascending branch of medial circumflex femoral artery. Medial circumflex femoral artery. Ascending branch of the lateral circumflex femoral artery, and sometimes even the inferior gluteal artery. Now let me elaborate a little bit on this. The two important blood vessels which supply the proximal part of the femur are medial circumflex femoral artery and lateral circumflex femoral artery, rather than superior and inferior gluteal artery. So remember this, okay? The second and third are the very, very important one. They form, okay, one, arcuate-like structure, a little bit distal to the capsule of the hip joint, and from there, different blood vessels will ascend up towards the neck of the femur and head of the femur, and they supply those particular structure. And this ascending type of vessel which ascend through the capsule of the femoral joint, they are known as retinacular branch. Okay, they are known as retinacular branch. So let me highlight that for you. See here, these are known as retinacular branch. So they are ascending up from the medial and lateral femoral circumflex artery upwards, and they supply the capsule as well as a neck and the head. Now the head of the femur is getting blood supply from some other sources as well. One of that is known as ligamentum teres. Now if you pay attention here, in the head of the femur, exactly at the center of the head of the femur, there is a slight depression. Okay, that is known as fovea capitis. Fovea capitis. Fovea means depression. From that fovea capitis, when ligament is attached, or in that fovea capitis a ligament is attached, that is known as ligamentum teres. Okay? Ligamentum teres. Now, this ligamentum teres is carrying one small blood vessel which is responsible for the nourishment of the head. But that blood vessel alone is not enough for the nourishment of head of the femur. We need some other sources as well. Okay, that is one small information. And don't forget about the nutrient artery. So let me ask this question: from where the nutrient artery enters the bone? From where? Anyone? We have done that before. Yes. What is the entry point for nutrient artery?
Gluteal tuberosity.
No, you talk generally first. Generally, in any bone, in a long bone, there is a nutrient artery, isn't it? You have studied that before. From where it enters into the bone?
Shaft.
Diaphysis.
Root shaft.
Shaft.
Of the bone. Okay, shaft or diaphysis or nutrient foramen. Very good. Now the answers are coming. It is right at the almost at the center of the shaft or diaphysis. There is a small foramen known as nutrient foramen, and there enters the nutrient artery. After entering into the bone, remember when it reaches the medullary cavity, it will divide into two branches. One is ascending up and one is descending down. Now that ascending type of branches of nutrient artery goes quite high up, and it uh, uh, it in gives branches to the different parts in the proximal end of the femur. That is also one of the supply for the proximal end of the femur. Okay, so with this, let's move further. Now, why are we talking or giving so much importance to this blood supply? Okay, if your teacher asks you, then you can very confidently answer like this: fracture of the proximal part of the femur disrupt it disrupt the blood supply from the diaphysis. The nearer the neck fracture is to the head, the greater the chance of disruption of the retinacular blood supply, which increase the risk of avascular necrosis. And this is very true. So the nearer the neck fracture is to the head, greater the chance of disruption of the retinacular blood supply. Remember what I told you in the beginning of the class regarding the intracapsular fracture of the neck of the femur. There are three types: subcapital, transcervical, and the basal. So subcapital fracture has the most important risk for the avascular necrosis because it is quite near to the head. Okay, so this is the point. Now, have a look here. What knowledge you have gained till now? Okay, look that in the form of a picture. These are the different branches. Medial circumflex femoral artery is here. Lateral circumflex femoral artery is here. Okay, see this? Sorry. Okay, it's here, right here. Medial circumflex femoral artery, lateral circumflex femoral artery. They are, anastomosing right at the, base of the capsule of the hip joint. This is known as extracapsular arcade formation, and from there the different branches are ascending up, and then they are supplying the neck and head of the femur. Now, what is the important knowledge you have to gain here? If the fracture occurs right here to the neck, now these blood vessels may be severely damaged, and though the head may get some supply from this area, this is called fovea capitis. Just pay attention here. Fovea capitis is right there. Okay, so there is a small artery which is entering here, but that's not enough for the head to survive. So there is high chance of a vascular necrosis of the head of the femur. This is also common in dislocation of the hip. Let's move on. Now, there is another picture which is showing you the same thing, even in a very good way. Okay. Now, see this, there is a femoral artery. This is called profunda femoris artery. Profunda femoris, or deep branch of the femoral artery, and this is giving rise to the circumflex artery, that is lateral circumflex femoral artery and medial circumflex femoral artery. They are forming one anastomosis around the neck, okay, which is outside the capsule, and so many important branches are ascending up and they are supplying the head and neck. So if fracture occurs right here across the neck, then these blood vessels are disrupted, leading to the avascular necrosis. Never forget this. So see there, another picture. Okay, one further blood vessels is shown here, that is ligament of the head, or also known as ligamentum teres, which is attached to the fovea capitis. See there, it is also getting a blood supply from this site. Okay, but the most important source is not this one. They are the retinacular blood vessels which are ascending up. Now, with this knowledge, let's enter into the classification of proximal femur fracture. Though you already know these terms, okay, already know these terms, it is very easy for you to understand now. So, all of you, please focus here. Now, fracture of femoral head and femoral neck fracture, we roughly divide into two types first. Okay, fracture of femoral head itself is very less common, because that femoral head is a rounded structure. Okay, so it is fractured only in very severe type of fracture, impacted type of fracture. It may be associated with dislocation of the hip, but more common type of fracture is femoral neck fractures. And look here, they're roughly divided into two types: intracapsular and extracapsular. Now, intracapsular is again divided into three types: subcapital. Okay, see there, subcapital. Capital means head, so just below the head is subcapital. Transcervical, right at the center or middle part of the neck, transcervical. And basal, okay, basal part of the neck. Very easy classification. So this is intracapsular. Why it is called intracapsular? Because they are still occurring inside the capsule of the hip joint. Another type is called extracapsular. Okay, extracapsular. So these are intertrochanteric and subtrochanteric. Intertrochanteric and subtrochanteric. We can also include transtrochanteric there, but that is not that very common, and many of the textbooks even though don't mention that term. So intertrochanteric and subtrochanteric are the important type of extracapsular fracture of the proximal part of the femur. Now let's focus on this picture, highly informative one. This is head of the femur. So see this. This is known as subcapital. This is transcervical fracture. This is basal fracture. This is intertrochanteric fracture because here is the greater trochanter, here is the lesser trochanter. So right through them, intertrochanteric fracture, and this is subtrochanteric fracture. It should not cross that 5 centimeter distance from the this lesser trochanter area. Okay, if it crosses more than 5 centimeter, then this is known as fracture of the shaft of the femur. So these are some of the very important knowledge. Now, okay, before I move further, I'll give you a bit of time, okay, few seconds time. So all of you, please focus on this picture, okay, and consolidate your knowledge. See there, please. Okay, so see that this is joint capsule. So joint capsule is attached proximally where? Once again, proximally acetabulum, isn't it? Proximally to acetabulum. Just remember that.
Well,
Okay, let's not complicate the things. There is something known as transverse acetabular ligament because there is a small gap in the acetabulum, so it is attached there also. But you can simply say proximally to the acetabulum and distally. Now distally, see there, this is joint capsule. Okay, this area is joint capsule. See there where it is attached, right in the intertrochanteric line, and proximally near to the intertrochanteric crest. So these are the different fracture here: intracapsular fracture and extracapsular fracture. They have not, mentioned the different types of neck of the femur fracture here. So subcapital, transcervical, basal, or basic cervical, whatever term you want to use. These are intracapsular one. Very nice informative diagram. Intertrochanteric fracture and subtrochanteric fracture. Excellent one to remember for the students. Okay, the same picture is repeated again because we are talking about the classification of the neck of the femur fracture. So this is one of the favorite questions in the Viva exam or even the theory paper because of the clinical importance of this fracture. That's why it is commonly asked in the exam. Now some other diagram. Okay, see there, there is a fracture. Okay, so which type of femoral neck fracture is this? Just tell me by looking at the picture, which type is this? This one which I'm showing right now.
Subcapital.
Subcapital. Subcapital. Excellent. This is subcapital because it is right below the head. Okay, right below the head. Subcapital. Wonderful. Subcapital type of femoral neck fracture. And it is already written here, intertrochanteric fracture. See this? Right through the two trochanter, greater and lesser. So this is intracapsular. This is extracapsular. Now, with this information regarding the classification of hip fracture, let's move further. Let's talk about what are the clinical features now. Fracture of the proximal femur is common in old people, usually after 60 years of age, as bones become weak by osteoporosis, okay, especially in the female. Because after they attain menopause, okay, the bones really become osteoporotic very quickly because that protection given by the estrogen is gone, so they become osteoporotic. And one of the very very important history you should never forget is when they slip on the bathroom or on the kitchen or on any floor, okay, just slip mildly, and when they fall, they can easily break the femoral neck easily. Adults or young adults or people who have a stronger bone, they don't break femoral neck so easily. So we can consider this as a pathological fracture in that particular age. Why pathological fracture? Because osteoporosis is already there and that bone is not normal anymore. So this is a type of pathological fracture. Okay, you can consider like that. Now regarding the clinical feature, see here, there is history of trauma or fall or road traffic accident. Any type of injury may be there. Simple fall, just slipping on the floor in very old patient, and significant trauma in the younger one, like road traffic accident or motor vehicle collision. Pain and tenderness in the hip is very common, and this pain increases on the movement. Or patient uh, cannot walk at all, okay, unable to walk because there is a serious fracture going on. Limb is abducted, externally rotated, and shortened in this type of fracture. See this? Abducted, externally rotated, and shortened in this type of fracture. This is a type of deformity which develops in femoral neck fracture. And because of this important, a clinical feature or sign, we can identify, yes, this lady has broken the femoral neck. So we all know the meaning of this term, so let's not go into them again. Movement of the hip restricted and painful, definitely. These are the very common features of any fracture. Now, okay, let's go to this individual type of the femoral neck fracture and let's see the related X-ray also. These are not the schematic diagram, these are the real X-ray. So you need to focus, okay, closely on this X-ray. First one is a subcapital fracture. It is just under the caput or head of the femur. That's why the term subcapital. It is quite common and frequently gives rise to avascular necrosis, that is also known as bone death. And why the avascular necrosis occur? If I ask this question, how do I answer? Why?
Because of
Blood supply is
the
compromised due to the fracture.
injury of the blood supply.
Exactly. So it would be better if you include the name of those blood vessels also. These are known as retinacular blood vessels. Retinacular blood vessels, they come from the anastomotic arcade, which is formed, okay, just outside the capsule of the hip joint, on the distal part of the capsule, of course, by medial circumflex femoral artery and lateral circumflex femoral artery. Okay, so that is the perfect answer you can give. Now let's focus on this X-ray here. This is arrow, small white arrow is shown here, and you can see there is a fracture line there. Okay, you see there is a line. So there is a fracture, subcapital fracture. This F is femur, this is head of the femur. Now there is one important term, okay, you need to know, that is Powell's angle. Okay, Powell's angle. Now, what is that Powell's angle is all about? See here. This Powell's angle is the angle between the line of a fracture of the neck of the femur and the horizontal axis as seen on an anterior-posterior radiograph. So one of the view we always take is AP view, another is a lateral view, and some other special type of views are also there according to the part of the body, okay, or joint which is affected. So in this case, we focus on the anterior posterior X-ray. Okay, so the angle formed between the line of the fracture, see this is the line of the fracture here, and the horizontal axis is called Powell's angle. This Powell's angle is named after the German orthopedician Friedrich Powell's. What is the importance of this Powell's angle here? The greater the angle, please pay attention, greater the angle, the more unstable the bone fracture is, and so worse the prognosis. Now, in this case, the Powell's angle is 30 degree. In the second one, the Powell's angle is 50 degree. And the third one, Powell's angle is 70 degree. So you can clearly tell me which fracture is having worse prognosis here. Which one?
70
70
degrees.
degree.
70 degree.
70 degree.
Very good. Of
70
course,
degree.
70 degree. Of course, 70 degree. Very good. The third one, the fracture which is having 70-degree angle or Powell's angle larger than other is very unstable type of fracture. And this is clear-cut case of subcapital fractures. Clear-cut subcapital. Now this is also looks like a bit subcapital, but on this side, it is a bit going towards the middle of the neck. And this is, see there, throughout, extending throughout the neck of the fracture. So I cannot clearly tell this as a subcapital. So subcapital fracture of the neck of the femur has the worst prognosis. You can say like that according to the Powell's angle. Let's move on. Now, another one is intertrochanteric fracture. Now, why this is intertrochanteric fracture? Okay, let's see the X-ray and try to find it out. See this. These are the two, white arrow, okay, thick type of arrows, and right in between them you can see the fracture line. Okay, you can see the fracture line. Not very clear actually because there is no displacement, but there is a fracture going. So this is intertrochanteric fracture, which is between the greater and lesser trochanter, and it is less common than a subcapital fracture. And of course, avascular necrosis is infrequent here. Okay, it is infrequent, means it is not very common. Why it is not very common? Because the chances of damaging those blood vessels which are going up is not very common. That's why the avascular necrosis is infrequent or less common in intertrochanteric fracture. Subtrochanteric is another one. Look at this fracture. It's a bad looking fracture here. See this area. Okay, so subtrochanteric fracture can be a transverse, spiral, or oblique fracture of the proximal femur that is located below the lesser trochanter. That's why we call it subtrochanteric, below the trochanter fracture. Now just look at the picture, the X-ray, and tell me which type of subtrochanteric fracture is this? Is it transverse? Is it spiral? Or is it oblique?
Oblique type.
Oblique.
Okay, this is oblique type. So don't you think this is a spiral fracture? Can you tell me this is a spiral fracture or not? Not really. For the spiral fracture, or to comment on the spiral fracture, I need to see both end of the bone, whether the end the bone is twisted or not. Okay, so it is difficult because see this, the lesser trochanter is on the normal side, greater trochanter is on the opposite side. They are not twisted. It doesn't look like that. This is the upper end of the bone, this is the lower end of the bone, and I cannot see it properly, but there is a small piece of the bone which is coming out here. So I can tell this as a oblique type of fracture. I agree with you. Now let's move further. See these two types of X-ray. Here is AP view of the fractured femoral neck. At right side, we can compare right with the left, and this is femoral head fracture AP view. Now, see this. Okay, though it is very nicely shown here, but that is not the objective of this slide. We want the students to really notice this, so that next time when you see this type of X-ray, you can clearly pick up the fracture line. Okay, that is the way. See this, here is the fracture line, and here, okay, here is also fracture there, and there is a clear-cut fracture line, okay, right through the head, not at the subcapital area, it is right through the head. See this up to here is the area of the head. It is occurring right a bit distal part of the head. These are the intertrochanteric fracture which occurs through the trochanteric line, greater trochanter, lesser trochanter. This is intertrochanteric line. So this is the normal intertrochanter epiview. I cannot see any fracture here, but this is a definite fracture line I can see. See this. Okay, and this is the lateral view. Here is a CT scan which is showing the same thing. This is the fracture line right through the intertrochanteric line. Now nobody can mistaken about this fracture anymore. Now see it very carefully. Can you see any fracture line there? Can you see it or not? Don't look at the headings of the slide. Okay, that is not the way. You have to see. You have to find it by yourself. Can you see any fracture line there or not? Sometimes after fracture, the two pieces of the fractured bone are impacted against each other. Okay, now listen carefully. They are impacted. What is impacted means what? What's the meaning of that?
Connected to
Compressed against each other.
Exactly. They are still compressed or connected with each other, but not in the same line. There is a slight disturbance in the line. Now just pay attention here. Yes, there is no straight line here. See, this fragment is coming a little bit distally, a little bit on this side, and this head is twisted. It is not properly aligned. So this is clear-cut case of something wrong going on here. Okay, so this is an impacted type of subcapital fracture. So this is how we reach to the conclusion. Now, if you are in doubt about this type of X-ray, take the lateral one. And still, if you are in doubt, go with CT scan. CT scan is always there. CT scan is much better than the ordinary X-rays regarding to judge whether the fracture is there or not. So we're talking about different types of fracture neck of the femur. We saw one X-ray which is showing the subcapital fracture before the break. Let's move on. Now, all of you, please focus on this X-ray. Which type of fracture is shown there? Though it is written there, but still you need to see the fracture line. So where is that fracture line present here? Okay, so see there. It is present between the two trochanter. This is intertrochanteric fracture. Look at the fracture line here. Okay, and a piece of bone is also separated in this area. Now, this is the X-ray which you have seen before. This is subtrochanteric fracture. Now, these are the schematic diagram of different type of fracture which you have talked till now. A few of them you have already talked. Subcapital fracture, transcervical fracture, intertrochanteric fracture. We are going to talk about this toward the end. Subtrochanteric, okay, fracture of the greater trochanter and fracture of the lesser trochanter. So these are the different types. So now your job is to look at the X-ray very carefully and try to diagnose this fracture correctly. Let's move on. Regarding the intracapsular fracture of proximal femur, there is one classification which is quite common from the exam point of view, or very important. That is Gardens classification. Okay, so according to the Gardens classification, we have Garden type 1, 2, 3, and 4. So what are those? Garden type 1 means is the incomplete fracture. Garden type 2 is a complete fracture without displacement. Garden type 3, complete fracture with partial displacement. And Garden type 4 is complete fracture with full displacement. Quite an easy one. Just look at the fracture line, just look at the alignment of those proximal and distal pieces of the fracture bone, and then judge yourself. Let's see once again this Gardens classification of intracapsular fracture of the femur. See this, Garden 1, incomplete and minimally displaced. This is incomplete fracture. The fracture line is only on one side, other side there is no fracture. Garden 2, complete fracture but non-displaced. Okay, I cannot see any displacement here. Garden 3, see this? Garden 3, complete fracture and partially displaced. And Garden 4, completely displaced fracture with no engagement of the two principal fragment. So this is, displaced a bit inferiorly, okay, and this has been pulled superiorly. So this is a clear-cut displacement and a complete fracture line. So this is Garden 4. Now, in some of the textbook, the Garden's classification is shown like this. Okay, the meaning is same. The meaning is same. Don't complicate the things here, but it is shown like this. That's why we have included it here. Stage 1, Garden's fracture, incomplete fracture of the neck. It is also known as impacted fracture. Impacted fracture. So I need to see it very carefully. You have already seen this type of X-ray before. Need to see very carefully for the fracture line here. Okay, and the neck of the femur also looks a bit shorter than before. So abducted or impacted fracture. Garden 1. Garden 2, complete without displacement. So complete without displacement. No displacement. They are still in the straight line. There's no shifting. Okay, this is the X-ray. Stage 3 or Garden 3, complete with partial displacement. Partial displacement. See there? They are not exactly in the straight line. Okay. And stage 4, complete femoral neck fracture with full displacement. The proximal fragment is free and lies correctly in the acetabulum, whereas the distal fragment is usually pulled up by the connection of the muscle. So there is a clear-cut displacement. So this is Garden 4, which has the worst prognosis among all. Now a little bit, exercise, a class exercise for you. So the answer is already written there though, but still we need to identify, because in the exam we don't write answer like that, in the slide. We only show you this type of picture or X-ray. So why did this is Garden grade 1? Why? Just see there and tell me why it is Garden 1. Anybody?
The line is
It
not
is
full.
complete and not
Incomplete fracture of the neck.
Okay, it may be incomplete fracture of the neck, or the fracture line is not seen properly, or probably it's an impacted type of fracture. See this is an impacted fracture on this side. See there, I can see small fracture line here. Okay, and this it looks like the neck is driven, inside the head. It looks like that. The neck looks a bit shorter to me. So this is a grade 1 type of fracture according to the Garden classification. Another one, see here, this is grade 4. This is Garden grade 4. Why it is Garden grade 4? The fracture line is complete here. This is fracture line, and this head of the femur is nicely, inside the acetabulum. This is acetabulum. Head of the femur is located nicely there, and this is slightly, displaced up. Not that major type of displacement though, but there is a slight displacement up. So this is Garden grade 4. It is not as easy as seeing those schematic diagram. This is a real X-ray, so we need to see it very carefully. Now, what are the investigations you like to do to diagnose this type of fracture? No doubt about it, one is X-ray, and that's what we are looking till now. X-ray of the hip joint or X-ray of the proximal part of the femur in the different view, AP view, lateral view. MRI and CT scan also can be done. In doubtful cases, we go for MRI or CT scan. Now, few of the X-rays are again, included here. This is a very good one. See this? Okay, clear cut. Okay, fracture line I can see. So Tell me the type of fracture here quickly. Which type of fracture is this?
Garden type 2.
Okay, Garden type 2. Good. And according to the another classification, what is this? Is it subcapital? Is it transcervical? Or is it basal? Which one you think? Or is it intertrochanteric? Which one?
Intertrochanteric.
Are you sure it is intertrochanteric? See this? Okay, so see there is a slight confusion still. This is the greater trochanter here. Okay, here is the greater trochanter. This is a small part of the greater trochanter. That's why you are confused. But lesser trochanter looks all right to me. And this is the intertrochanteric line. The fracture line is above the intertrochanteric line. It is above. So I still go for a basal neck fracture here. If this is a intertrochanteric fracture, the fracture line should be somewhere here, okay, in this area, a little bit inferiorly. So this is basal fracture of the neck of the femur. Now, one important concept which you have done a long time ago when we are dealing with the basic things about orthopedics is called sentence line. Okay, sentence line. Now see there, what is the importance of this sentence line in this type of cases? So look at the normal sentence line first. This is the sentence line. The line which is drawn in the green color is the sentence line. This is the normal one. So draw a line from the inner aspect of the proximal part of the femur, okay, and go towards the pelvis. It will go through the pubic ramus. It is normal. Now, if this sentence line is disrupted, okay, disrupted, that means there is something wrong. Either there is dislocation of the femoral head or there is fracture of the femoral neck with displacement. Then only the sentence line is disrupted. So this is one of the important questions which can be asked for you in the exam. Normal is about 120 to 130 and it is disrupted in this type of phenomena. Dislocation of the femoral head is one, and fracture of the femoral neck with displacement is the another one. Here is the fracture through the femoral neck. It is very nicely shown with the dotted, lines there. Clear-cut fracture you can see. Okay, another X-ray. See here, clear-cut fracture. On this side there is no fracture. You can clearly see there is no fracture here. This is a femoral head. Okay, the neck I can trace it quite nicely. See this, no fracture. But here, see this, there is a fracture line. Okay, there is a fracture line. MRI is another investigation which we can do in this type of cases, and MRI is both sensitive and specific in the detection of femoral neck fracture because it can show both the actual fracture line and the resulting bone marrow edema. And this is very sensitive because this is a advanced type of imaging, isn't it? So the sensitivity and specificity are far superior than the ordinary X-ray. Just know that much. See here, these are the different MRI films. You can see the thickening of the cortex, effusion of the joint, and so many other very minor, pathology you can detect with the help of MRI. So fracture will of course be detected. See this, the small cracks also can be detected on the head. This can be easily missed by the X-ray. Okay, here there is a fracture line, so like that. Okay, these are the edematous areas. Now, how to evaluate a patient? How to evaluate a patient with this type of fracture, and how to judge which type of management we should go for. This is a very important decision. So let's talk about it. For emergency and for the new case, immobilization and use of injection or oral form of analgesic is really important in the beginning because it is quite a painful condition and immobilization and use of proper analgesic is important. Now, either we can give oral or injectable form of analgesics, and the commonly used analgesics are NSAID again. Okay, NSAID, and they are available in both of the form. Settle down the patient and try to improve the general condition of the patient, definitely. For the old cases, it is necessary to take plan after evaluating all the investigation and also the recent condition of the patient. Now, what does that mean? Sometimes the patients are quite old, around 80 or 85-year-old. And remember, for the old age, if surgery can be done, the best modality of treatment is surgery. And what type of surgery? You replace the joint. That is called hemiarthroplasty or total hip arthroplasty itself. But before taking the decision, we need to see what's the general condition of the patient also. If the patient is having terminal stage of COPD, okay, it can be seen in older people. If they are having very high blood pressure, if they are having severe bronchial asthma, if they are having heart disease or heart failure, uncontrolled diabetes, we cannot take them for those complicated surgery. So we need to manage in some other way. That is the point. So here, fracture neck of the femur in older patient. Okay. What should we do? In older patient above 60 years, such fractures are treated by removing the head of the femur and replacing it by metal prosthesis like Austin Moore prosthesis. This enables the patient to be ambulant and start early weight bearing. This is a very important principle of treatment here. In older patient, if their health allows us to go for the surgery, we definitely go for this type of surgery. So what we do, remove the head of the femur because probably it is already ischemic. There is a high chance of development of vascular necrosis there. Let's remove that head and replace this with a prosthetic material that is known as Austin Moore's prosthesis. In fracture neck of the femur in children now, what are we going to do? The fracture is reduced by manipulation and the leg is immobilized in full plaster spica in abduction position for 8 to 10 weeks. Now, plaster spica, okay, is is a form of plaster of Paris which is applied from the lower part of the body. Lower part of the body, it covers the gluteal area and it is coming way below in the lower limbs. This is called spica. Only the area which is necessary for urination and passage of the stool is cut open. That should be left open, isn't it? Otherwise, how can the patient pass urine and stool? Only that area is left open. All the other area is covered under plaster. That is called spica. So in children, we can go for this type of management. When indicated, internal fixation could be done with multiple thin Austin Moore pins also. So this is another option. Okay, let's move on. Now, treatment depends upon age, which we have just discussed, nature and duration of the injury. Nature and duration of the injury also. The plan is, if the fracture is not displaced, if it is not displaced, let me underline this, internal fixation by 2 or 3 parallel screw for adult and null spin for the children. So internal fixation is commonly applicable here by 2 or 3 parallel screw for adult and null spin for the children. So this is commonly done. But if the fracture is displaced, okay, if it is displaced, and now we look for the age, less than 65 years of age, we go for close reduction and internal fixation by the screw and pin. Close reduction and internal fixation by the screw and pin. So this can be done, and age more than 65, we go for excision of the head, means remove the head and replace it with prosthesis, and this surgery is known as hemiarthroplasty. This is a very, very important concept for you, and this question is asked by many teachers. So according to the age, we decide what to do. According to the displacement, we decide what to do. Okay, according to the nature of the injury, we decide what to do. In elderly patient who are medically well and still active, a total hip replacement may be indicated. Total hip replacement means what? What do you mean by that total hip replacement term? Anybody?
Remove the actual head of the femur and replace another one artificially.
Okay, only head? You mean only head or something else? Remember, this is total hip replacement. So what are the two parts of the hip joint? Once again,
acetabulum and head should be removed.
exactly. See there, listen to the term properly. Hemiarthroplasty means half of the joint. In this case, we are talking about fracture neck of the femur. So head is removed here, not the acetabulum. Only the head is replaced. Whereas in total hip replacement, we remove both head as well as acetabulum. That acetabulum is also having a lot of problem probably during this case. These patients are quite older. Who knows? They're already having a disease known as osteoarthritis inside the hip joint. And if that is the situation, you better go for replacement of the both. That is known as total hip replacement. Okay, this is another question which we love to ask to our students. But the meaning is right there. Just pay attention there. Let's move on. See this? These are the different, internal fixation device. Austin Moore pins. Okay, this is called Knowles pins, and this is in a magnified view. So Knowles pins in magnified view. See this? These are the pins which are inserted. So this is close reduction and internal fixation. Sometimes the surgeon even don't open that area. With the radiographic review, they can insert the pins from outside without giving any or reaching that surgical site. So this is still considered as a close reduction and internal fixation. This is a very good type of surgery. See there? It's a very nice fixation there. Now, internal fixation for fractured neck of the femur for younger patients can be done like this. This is a percutaneous cancellous screw fixation. Okay, and this is fixation with a DHS and derotation screw. DHS is known as a dynamic hip screw. Dynamic hip screw means it can give compression to that fracture site. That's why it is known as dynamic. This is a very important way of fixation of a fracture. Now look at the fracture here. It is displaced type of fracture. You can clearly see, and it is a complete type of fracture. Okay, so to fix this fracture, DHS is the perfect instrument. One long screw we can fix here on the proximal side, and the main DHS will take care of the other. Okay, dynamic hip screw and derotation screw. Now tell me, this dynamic hip screw is a part of open reduction and internal fixation or closed reduction and internal fixation? Yes, just look at the picture and tell me.
Open.
Exactly, this is ORIF now. This is ORIF, because see, look at the plate. Where is the plate? It is attached right at the surface of the bone. So we need to reach this fracture site. There's no other way. So this is a perfect example of ORIF, open reduction and internal fixation. Now let's summarize or revise. Okay, what are those treatment guidelines we are talking till now? See here, this is a very important slide. This is a age group here. This is a undisplaced fracture, and here is a displaced fracture. How we are going to treat? in these cases. If patient is more than 70 years and if the fracture is undisplaced, we better go for dynamic hip screw. Dynamic hip screw, the picture you have just seen. Okay, there is a long plate which will give compression and there are multiple screws there. If the age is more than 70 and fracture is displaced, you better go for prosthesis. Prosthesis, okay, either hemiarthroplasty or total hip replacement. Hemiarthroplasty or total hip replacement. Anything can be done. Young adults, if there is undisplaced fracture, you treat by dynamic hip screw, straightforward case. And in case of displaced fracture also, we can go for dynamic hip screw in those after proper reduction. Or another way is osteotomy or prosthesis. This is just the alternative. Osteotomy is cutting a bone there and manipulating it, In children, you go for hip spica if there is undisplaced fracture. We already explained this. Or you can go for multiple Moore spinning. This is subcutaneous Moore spinning. And displace multiple Moore spinning, osteotomy, okay, and even go for arthrodesis. Arthrodesis. Now, arthrodesis is a surgical immobilization of a joint by fusion of the adjacent bone. Now, this is not an easy decision in the beginning. They always wants to go for the better option. If these are failed or something like that, some complication happened, then only think about the difficult one. Okay, so these are the very good guidelines for us. Now, let's see this slide. Okay, this is a very good one. Just to revise the things which we have done till now. Just take a bit of time here. What is the first one here? See this? These are the percutaneous cancellous screw. So what type of surgery is this? According
Close
to
surgery.
Close reduction internal.
very good. Closed surgery or closed reduction and internal fixation. Excellent answer, because it is a percutaneous one. Okay, they are passing it through the skin, percutaneous. Excellent. This is undisplaced type of fracture treatment in a young person. In the old person also we can go for this, or you can go for this. See there, arthroplasty. This is open reduction and internal fixation by dynamic hip screw. This is called dynamic hip screw. It is right attached on the surface of the bone. So this is open reduction, internal fixation in a displaced fracture. And this is hemiarthroplasty or total hip arthroplasty. But which is this, hemi or total? Just look at the X-ray and tell me, is it hemi or total?
So total.
Hemi.
Now once again,
Hemi.
hemi means only the head of the femur. Okay, head of the femur is replaced, and total means both acetabulum and head of the femur are replaced. So which is replaced here? You can clearly see in front of your eyes here. See?
The head of the femur.
Exactly, only the head. See this? Only the head is replaced. See, look at the bone. This looks like a normal bone to me. This acetabulum looks like a normal cavity to me. It is not the artificial one. Only the head side is artificial. So this is hemiarthroplasty. Let's move on. This is another beautiful picture which is showing screws, okay, and they are applicable through the fractured bone in place. These are the fractured bone. It is nicely going through it. Excellent type of fixation. Now see this, okay, we are talking about orthopedics, so a lot of internal fixation device will come into the picture all the time. This is a femoral neck fracture, is a displaced one and a complete type fracture, and this is the excellent way of fixation. Okay, excellent way of fixation. See here, this is intertrochanteric fracture. So, and see how they are fixing it. Another wonderful way. Okay, it's a complete type of reduction, and there is not even 1 inch which is shifted here and there. This is called dynamic hip screw. which is fixing the fracture. This is another fracture, okay, of the neck of the femur, and again dynamic EB screw with another extra screw is there to fix the fracture. This is a appearance of dynamic EB screw from the frontal side. This is the lateral side, this is the frontal side. Okay, so this is the wonderful way of treating this type of fracture. Remember the term dynamic hip screw, DHS, okay, commonly used device all over the world. Now with this, okay, let's talk a little bit about hemiarthroplasty, but many of the students, they already have this concept of this already. See this, hemiarthroplasty is a surgical procedure which replaces one half of the joint with an artificial surface and leaves the other part in its natural state. And usually we replace the head of the femur and leave the acetabular cavity like that. Okay, then it is hemiarthroplasty. This class of procedure is most commonly performed on the hip after a subcapital, just below the head fracture of the neck of the femur. It is the most complicated type of femoral neck fracture. According to Powell's classification or Powell's angle, you know, this is the fracture which has the worst prognosis. According to Gardner's classification also, there is a high chance of grade 4 fracture in case of subcapital 1. The procedure is performed by removing the head of the femur and replacing it with a metal or composite prosthesis. Metal or composite. Composite means different type of substances are mixed together. That is the meaning. We really don't care what are those substances there, okay? It is already available inside the operation room. You just ask the nurse or the assistant, can you give me the prosthesis? It is already there. You just fix it there. The most commonly used prosthesis designs are the Austin-Moore prosthesis and the Thompson prosthesis. So these are the two special type of prosthesis which are most commonly used, Austin-Moore and the Thompson. It's just the name of the prosthesis. Now let's see this type of prosthesis. Now, see here. This is Austin-Moore hip prosthesis. Okay, this is how it looks. It has a long handle-like thing there, and this is a rounded head. Okay, almost looks like a femoral head, and there is a slight neck also. Okay, then neck shaft angle is also maintained, and this is how it is applied on the patient. See there, very nicely, you know, inserted into the acetabular cavity. So Austin-Moore prosthesis, perfect example of hemiarthroplasty. This is Thompson prosthesis. This is Thompson prosthesis. So there is a slight difference between Austin-Moore and the Thompson. Nobody is going to ask you what are those differences, okay? Because you are right now studying MBBS. This type of question should be asked to those residents who are doing masters in orthopedics. Okay, you just know the name of those prostheses, and that is also a maximum type of knowledge for you. If you know the meaning of hemiarthroplasty and total hip arthroplasty, you are done here. Now let's see some of the x-rays. This is hemi replacement arthroplasty, okay, and they say this is a total replacement arthroplasty, but still we cannot see it properly, okay, the thing which is changed there, okay, cannot see it properly, but this is a hemi replacement arthroplasty, and this is you know, according to the x-ray, it is a total hip replacement, but for the total hip replacement I still need to see some artificial device in the acetabular side. But one important clue is given there. Okay, now any student can pick what is that clue which is given there for the total hip replacement indication. Just compare this x-ray and this x-ray. What can you see in this x-ray here? Anybody?
Screw in pelvis.
Say it again.
There is a screw in pelvis.
Okay, Anything else? See this. There is a nice gap between the head of the femur and acetabular rim. I cannot see any gap here. So this is a clear indication that this joint has developed osteoarthritis. Osteoarthritis. Okay, almost they are touching with each other. Severe osteoarthritic changes are already developed there. In this condition, both surface of the joint has to be changed. That's what I told you before. Now, let's move further. We are coming towards the end of this discussion. Management according to the Gardens classification now. What are you going to do according to that Gardens classification? Remember, those Gardens classification have 4 different types. So in Garden 1 and 2 and Garden 3 and 4, these are the different types of management. There's nothing a difference there, okay? This is just management according to those classification. We are listing it here. Non-displaced fracture, Garden 1 and 2, this occurs mainly in relatively young patient, either chronologically or more important physiologically young patient. They should have urgent internal fixation via 3 or 4 parallel partially threaded cancellous screw, like Moore's screws, okay, or Moore nails. So these are the commonly used things. Chronological and physiological, don't get confused. Chronological means real age of the patient. Physiological means healthy looking patient. Sometimes patient is already 60 years but looks like 40 years, isn't it? So that is the meaning. Now, displaced fracture, Garden 3 and 4, there is a replacement of the femoral head to obviate the risk of avascular necrosis. There is a high chance of death of the femoral head in this severe fracture. So why to have that complication later on? Let's replace the head right now. That is the point. And this is often done via hemiarthroplasty. In younger, fitter patient, okay, they are being offered a primary total hip replacement in center able to provide the service. This is very important knowledge. Not only in the damaged joint, but in the younger and fitter patient also, we go for total hip replacement right in the beginning. But that's a particular orthopedic center should be able to do it without any complication, because total hip replacement is a big type of surgery and there should be proper expertise there. Now, one small question I like to ask here: why in the beginning itself they want to go for total hip replacement and not later on when they develop some complication? Why is that? Anybody? Okay, this is a bit of difficult question probably. Now listen properly. After you use prosthesis like Austin Moore's prosthesis or Thompson prosthesis, this prosthesis is a artificial device. It's a metal device, so it keep on causing some amount of trauma to the naturally occurring acetabulum there. And after few years, definitely there will be the development of osteoarthritis or degenerative joint disease. So why to take that chance? Okay, if they can go for this total hip replacement right now. So that is the explanation for choosing total hip replacement even in younger and fitter patient. Okay, so see this. So these are the different things: hemiarthroplasty, total hip replacement. Now this is a very good schematic diagram. If you pay attention, the acetabular rim is a natural one, is the normal one. See there, it looks like a bony one. But here, look at this. It is not bony anymore. It is already replaced. It looks like the artificial one. Okay, so this is a very good schematic diagram of total hip replacement. That's what I was talking before. And this is the internal fixation, probably subcutaneous one. This is a dynamic hip screw. So this is closed reduction and internal fixation. This is open reduction and internal fixation. So by this time, every student are quite confident about these different types of ORIF, closed reduction or internal fixation, and open reduction and internal fixation, and some artificial device like hemiarthroplasty and total hip replacement. Okay. Okay, let's continue. What are the post-operative care we like to do after surgery in case of hip fracture? The proper post-operative care would be use of proper post-analgesic care, because it's a painful procedure. Any surgery is a painful procedure. In this case, this is a major type of surgery. If they have done, ORIF or hemi arthroplasty or total hip replacement, it's a very painful procedure. So good analgesic care has to be given. Hypovolemic management for the patient with IV saline and blood if needed. In the beginning, always IV saline, normal saline or lactated drinker, then if necessary, followed by blood. Use of appropriate antibiotic for the patient if necessary, and good care of the operative wound, that is dressing according to the condition of the wound has to be done. So these are necessary post-operative care. Let's move on. Now, what are the post-operative complications that are common? See here, we have divided this into early and late type of complication. Now, early complication may occur from the post-operative day to the first post-operative day. I mean, from the time of surgery to the first post-operative day. That is a better explanation. Patient may have hypovolemic shock, and that is because of oozing due to inadequate hemostasis. Oozing due to inadequate control of the bleeding. From second to fourth day or post-operative day, patient may have skin reaction and infection in the operative wound. So these can occur, these do not occur in all the patient, but this can happen. Regarding the late complication, erosion of the acetabulum, erosion of the acetabulum, probably because of hemiarthroplasty, and dislocation of that joint, or dislocation of the artificially kept device like Austin Moore prosthesis can also occur. Okay, so let's move on. Now, what counseling you give at the time of discharge to the patient? This is very important. So during discharge, we exactly have to tell like this to the patient. Take enough rest for 12 weeks, quite important. Go for early mobilization as far as possible. In the first 3 months, okay, mobilize with non-weight bearing. Second and third month, partial weight bearing, then full weight bearing. So these are the important point. And monthly X-ray for 6 months, just to make sure whether the fracture is properly healed or not. Now, after doing this, the last part of this topic is left behind, that is extracapsular fracture neck of the femur. This fracture occurs from the basal part of the femoral neck to about 5 centimeter below the trochanter. That is 5 centimeter below the lesser trochanter. We have discussed this before. If a fracture occurs still below than that 5 centimeter border, then it comes under fracture shaft of the femur. It is a fracture shaft of the femur, so it is treated like that. Essentially, extracapsular fracture of the femoral neck occur distal to the insertion of the joint capsule. That's why the term extracapsular, through an area of well-vascularized metaphyseal bone, and that bone is relatively weak, so it can fracture easily. Now, signs and symptoms are similar to the fractured neck of the femur because the site is quite nearby. So let's talk about what are the differential diagnosis of extracapsular neck of femur fracture. Important question in the exam. So think about some related condition at that area, like intracapsular, okay, like intracapsular neck of femur fracture or femoral shaft fracture. Of course, they can be the important differential diagnosis. Let me underline them. And femoral shaft fracture. Another one is severe osteoarthritis of the hip or fracture of the osteophyte, which are a common feature of osteoarthritis. Acetabular or pelvic fracture. Septic arthritis of the hip. This is the pus formation inside the hip joint. Radicular pain from spinal pathology, like a disc prolapse, okay, and Schwarz abscess This is abscess formation in the psoas major muscle. All of these can be considered as a differential diagnosis because few of the features matches with each other. Okay. Now, let's talk about the management of the extracapsular fracture of the femur. Now, we especially go for dynamic hip screw or DHS surgery, and in this case the screw is inserted into the neck and the head. We all know that it slides freely in the barrel of the plate, which is secured to femoral shaft, and this allows fractures to compress. That's why it is known as dynamic hip screw. Remember the meaning of dynamic, it gives compression to the fracture site. Another way is the intramedullary fixation device. It's similar to DHS, but the force is transmitted to the short proximal intramedullary nail. So this is just another option, in case of ORIF. Now see this is dynamic hip screw. You can clearly see it. Okay, these are the multiple screws, and this is the dynamic hip plate. Now, in case of undisplaced fracture of trochanteric fracture, we go for immobilization by surface traction or skeletal traction for 6 to 12 weeks. Remember, in the beginning of the fracture lecture, we talk about this. This is one of the type of management of the fracture in that region. Surface traction or skeletal traction for 6 to 12 weeks. And in case of displaced fracture, you have to go for close reduction under general anesthesia and fixed by dynamic hip screw. Okay, or open reduction and fixed by dynamic hip screw. All these things are quite important. Now, at the end, this is the treatment algorithm for fractured neck of the femur. We have done this so many times, but at the last time, or for the last time, let's repeat this again. This is Garden 3 and Garden 4 types of femoral neck fracture. If a patient is young, that is less than 65 years, with good bone stock, low degree of comminution, we go for ORIF. That means the grade of osteoporosis is not that high. And in case of older age, that is more than 65, or poor bone quality or osteoporotic bone and high degree of comminution, you go for arthroplasty, either hemiarthroplasty or total hip arthroplasty. See that? Look for patient factors. Look whether that hip joint is normal or abnormal, osteoarthritis or rheumatoid arthritis. And if no osteoarthritis or rheumatoid arthritis, we can go for hemiarthroplasty. If it is already there and the joint is already badly damaged, you go for total hip arthroplasty. That means both the acetabulum and the head of the femur are replaced. Okay, this is the overview of the hip fracture. See this, there are 3 important types of fracture which are mentioned here: femoral neck or subcapital fracture, intertrochanteric fracture, and the subtrochanteric fracture. So these are the things you can do on your own. These are the definition, these are the mechanisms of the fracture, okay, investigation and different treatment as well as complication. It is about the subtrochanteric fracture here. Okay, so with this, let me stop this discussion now.